Dr. Nadir, I can start whenever we are ready.
Okay, let me just share my screen and then I think we can. So today, hello everyone. Today we're gonna start our Zoom meeting. Okay, Mihir, you can take it from here. Thank you.
Thank you, Dr. Nadir. So, hello everyone. So today we welcome everyone from a Brown team. My name is Mihir Trivedi. I'm the host for today, moderator. And we're gonna have a few presentations today, starting with my own for a critical appraisal on article. So I'm going to share the screen. Can you guys see my screen?
Yes.
Yes.
Okay. Thank you. So it's all about article appraisal using CASP, which is Critical Appraisal Skills Program. It's an online tool for article appraisal. So let's see. Okay. So before we go a little any further, I would like anyone to volunteer. I would like to ask a few questions. Anyone available, please? Or I can just probably pick randomly somebody. Let me see. Let's see. Dr. Bijay, you available? Hello?
Hi, sorry, I just joined the meeting, so I could not get you yet.
Oh, okay. Just one person I need. All right. Oh, anyways, I'll just pass that then. So basically, appraisal, something when we hear about those people who in US and probably own the house, they probably heard this term very frequently about their house being appraised or was appraised for selling or buying purposes. Means basically you're having to know that how much your house worth it, whether the asking price is equal or to that level or not. So same way with our whatever the research we do in our research practice, we want to know whatever the article we are using in our practice, we want to make sure that article is is actually to the point towards it's worth it to go through. It has up to its quality, or the information provided into that particular article is actually useful for it. So the whole process we do, it's the assessment we do is called a critical appraisal, basically. So it's the process of carefully and systematically examining research to judge its trustworthiness and its value and relevance in a particular context. So that allows clinicians to use research evidence reliably and efficiently. It is also intended to enhance the healthcare professional skills to determine whether the research evidence is true without having any biases and relevant to their patients. Next is that allows us to reduce information overload by eliminating irrelevant or weak studies. Critical appraisal also identifies the most relevant papers, distinguish evidence from opinion, assumptions, misreporting, and belief. It also assesses the validity of study, assesses the usefulness and clinical applicability of study. It also recognizes any potential for bias. So, excuse me, when we actually come to the like trying to find any evidence-based article, we first of all define what we need, we search for it, then we assess it, we appraise that, then we put all the data together, synthesize it, and then we adapt into our practice, we implement, and then we evaluate that. So critical appraisal is an important element of evidence-based medicine. The 5 steps of evidence-based medicines are asking answerable questions, like formulating questions into a format whereby you can interrogate the medical literature and hopefully find an answer. To do this, you may use the PICO tool. We all familiar with that. We had a presentation previously, so which helps to break down the query into query, intervention, comparison, outcome. You then need to search for the evidence. If you can find a pre-appraised resource, you can miss out the next step. So next step is critical appraisal of your results. You then decide what action to take from your findings. Finally, you evaluate your new or amended practice. So it is more like this. So if you have a clinical problem, then you're defining your questions using a PICO tool. Then you search, you're trying to find the evidence using any platform like a PubMed or CINAHL or Cochrane library, whatever. And then you appraise it using a critical appraisal tools, which we're going to discuss about it shortly. Then you decide what are the outcome, what are the results, and then you evaluate that. So how to critically appraise a paper? Some key questions to consider when critically appraising a paper. Is the study question relevant to my field? Does the study add anything new to the evidence in my field? What type of research question is being asked? A well-developed research question usually identifies 3 components: the group or population of patient, the studied parameters like, for example, therapy or clinical intervention, and outcomes of interest. Was the study design appropriate for the research question? You can learn more about different study types and hierarchy of evidence here also in this group. So did the methodology address important potential sources of bias? Bias can be attributed to chance, for example, random error, or to the study methods like systematic bias. Was the study performed according to the original protocol? Deviations from the planned protocol can affect the validity or relevance of a study. For example, a decrease in the studied population over the course of a randomized control trial. Does the study test a stated hypothesis? Is there a clear statement of what the investigators expect the study to find, which can be tested and confirmed or refuted? Were the statistical analysis performed correctly? The approach to dealing with missing data and the statistical techniques that have been applied should be specified. Original data should be presented clearly so the readers can check the statistical accuracy of the paper. Do the data justify the conclusions? Watch out for the definite conclusions based on statistically insignificant results. Generalized findings from a small sample size and statistically significant associations being misinterpreted to imply a cause and effect. Are there any conflicts of interest? Who has funded the study? And can we trust their objectivity? Do the authors have any potential conflicts of interest, and have this been declared? So next, the last and the most important question you want to ask is, will the results help me manage my patients? At the end of the appraisal process, you should have a better appreciation of how strong the evidence is, and ultimately whether or not you should apply it to your patients. Next is a critical appraisal of different study design. Now, when we are talking about research, we of course want to see what it applies to which kind of study. So to critically appraise a journal article, we need to start by assessing the research methods used in the study. And this is done using a checklist which are specific to the study design. There are following checklists which are commonly used. Critical Appraisal Skill Program, CASP, which is we're going to talk in detail about it. Then there is another one, it's called SIGN Guidelines Methodology Checklist. The Center for Evidence-Based Medicines as well. So Critical Appraisal Skill Program, CASP. So the web page is looks like this, and I'm gonna get into the web page so we can talk more in detail about it. But before we get into that, let's see what CASP is. So the Critical Appraisal Skill Program has over 28 years of significant and unrivaled expertise in the delivery of training to healthcare professionals. CASP has a series of easy-to-use checklists to help you read research, and also delivers training through face-to-face workshop, online learning, virtual workshop, and train-the-trainer courses. Using critical appraisal skills and tools enables users of research evidence to reach their own judgments. Are the CASP checklists a validated tool? The CASP checklists were developed as a pedagogic teaching tool for use within our workshop setting. They would be used to show the process of how to critically appraise and sorts of questions people should be aware about, therefore increasing their critical thinking. They are usually used within the small and large group work and discussion. Therefore, they were never formally validated. So let's, I'm gonna get out of this presentation, and I'm going to go into the web page. Yeah, can anyone see this?
Yeah, we can see it.
All right. So CASP, so basically the web page looks like this. So when you go into the tab checklist, there are several study designs they have done the checklist on. So as you can see, CASP randomized control trial checklist, systematic review checklist, qualitative study checklist, cohort studies checklist, diagnostic study checklist, case control. So we're gonna go through few of them. So first of all, I'm gonna go through one for systematic review, how to use this tool. So basically most of this checklist has 3 main sections, except one for RCT. So first section is talking more about, are the results of study valid? It's more about the validity of the study. Then second section is more about what are the results, and third is, will the results help locally? So there are a series of questions under each and every section. So if you see paper for appraisal and references, first sections, are the results of review valid? So the question, did the review address or clearly focus on questions? You can say yes, can tell no, and there are some hint over here. If it is, can be focused in terms of the population studies or the intervention given or the outcome considered. Then did the author look for the right type of papers? You can also see address the hint here. The best sort of studies would either address the review questions, have an appropriate study design. Is it worth continuing? So in this one, do you think all the important relevant studies were included? Similarly, you can go through those hint over here. did the reviews authors do enough to assess quality of their included studies? There are some hints as well here. If the results of the review have been combined, was it reasonable to do so? In the section B, what are the results? Under that, what are the overall results of review? How precise are the results? Can now the section C, under that, can the results be applied to local population? Were all important outcomes considered? Are the benefits worth the harms and costs? So like that. So this is one on, we just go through the systematic review. And before we jump onto other one, I just want to formally show a little bit and just trying to do some brainstorming. So let's go onto here. Let's go onto the PubMed website and let's pull up any topic. Let's say hip surgery in older adults. Okay, and here we have some results, and I'm gonna click on a free full text, and I'm gonna actually click on systematic review. So let's get into the systematic review, and let's see, there is a one here, looks like one for anesthesia for hip fracture surgeries in adults. Let's take that, and there is a full article over here. And now we just want to see whether we can imply all those questions here. So let's pull this up again for systematic review. So basically, three main questions we want to ask. Are the results of study valid? What are the results? And will the results help locally? So we want to see what kind of methods were done, objectives. We want to see how the data collection and analyze were done. So we want to see, this is the main result here. The CI, RR, and the p-value always helps to determine the effectiveness of the results. And then we want to see whether that results helps us locally or not. I want to go on the next one. This is about a case control study. Same thing, CASP checklist. There are 11 questions. Same as I said earlier, 3 sections. All those questions are divided into those 3 sections. Section A, did the study address or clearly focus issue? So almost the same questions here. Again, did the authors use an appropriate method to answer their question? Is it worth continuing? Whether assess a case recruited in acceptable way. There are some hints over here next to it. We are looking for selection bias, which might compromise the validity of the findings. Are the cases defined precisely where the case is representative of a defined population? So again, about was there an established reliable system for selecting all the cases? Is the time frame of the case study relevant to disease or exposure? Was there a sufficient number of cases selected? Was there a power calculation done? Were the controls selected in an acceptable way or not? So were the controls representative of the defined populations? Was there something about special about those controls? Was the non-response high? Could non-respondents be different in any way? Are they matched population based on or randomly selected? So was the exposure accurately measured to minimize bias? Aside from experimental intervention, were the groups treated equally? Have the authors taken account of the potential confounding factors in the design and or in their analysis? Again, in the what are the results section B, how large was the treatment effect? How precise was the estimate of the treatment effect? Do you believe in the results? Again, section C, can the results be applied to the local population? Do the results of this study fit with other available evidence? So I'm not going to go through all those checklists, but I would still like to go through on RCD because this is a little different. So let me pull up that. No, this is it. Okay. So in this clinical trial studies, as I said earlier, that in this one, RCD has 4 different sections. So is the basic study design valid for a randomized controlled trial? Section A. Section B, was the study methodologically sound? Section C, what are the results? Section D, what will the results help locally? So similar questions, just a little different for RCD. There are questions like, did the study address a clearly focused research questions? Was the assignment of participants to intervention randomized? Were all participants who entered the study accounted for at its conclusion? Were the participants blind to intervention they were given? Were the investigators blind to the intervention they were giving to participants? Were the people assessing or analyzing outcomes blinded? Were the study groups similar at the start of the randomized controlled trial? So you gotta consider were the baseline characteristic of each study group, for example, age, sex, socioeconomic group, clearly set out. Were there any differences between the study groups that could affect the outcomes? Last questions under this section is, apart from the experimental intervention, did each study group receive the same level of care? That is, were they treated equally? Section C, were the effects of intervention reported comprehensively? Was the precision of the estimated of the intervention or treatment effect reported? Do the benefits of experimental intervention outweigh the harms and costs? In section D, can the results be applied to your local population or in your context? Would the experimental intervention provide greater value to the people in your care than any of the existing intervention? So that is it. So when we actually go to, you can also similarly go through for qualitative studies, cohort studies, and other studies as well. So, any questions so far? All right. Thank you so much for everyone for listening this, and thank you so much, Dr. Nadir, to give me this opportunity. And would you like to say something, Dr. Nadir?
Thank you so much, Mihir, and the group, the team. This is excellent. I think this is great. So we're gonna use this in the near future. So we're gonna send you guys an article maybe, and then we can work on getting that point across using this tool. It's very useful tool. So hopefully it will help you. And most of the time we use it in the journal, like Journal Club. When you go into residency, you can use it, or you can use it for your own text when you have some articles you want to go over. Thank you so much, Mihir. This is an excellent presentation.
Thank you so much, Dr. Nadir. Thank you.
Thank you.
So our next presentation is a mock interview. We have multiple interviewers here. So I would like Dr. Bijay Shrestha, Dr. Niki Shrestha, and Dr. Naureen Syed, and Dr. Sushma Srinivas to go with their interview.
Thank you, Dr. Mihir.
And
also I would like to thank you, Dr. Nadir, for giving this opportunity for us. So our next session for today will be like mock interview, and we are 4 participants today. I myself, Bijay, and I'm with Dr. Sushma, Dr. Naureen, and Dr. Niki. So we have to make it more organized. We have divided our session into 2 sessions. So first one will be, I will be with Dr. Sushma, and we'll try to finish the first session in 15 minutes, and next session will be with Dr. Niki and Dr. Naureen. So yeah, so I would like to begin the first session. Hi, Dr. Sushma, are you ready to go?
Yes, Dr. Shrestha.
Okay, so let's begin, okay? Hi, good afternoon. How are you doing, Dr. Sushma?
Good afternoon, Dr. Shrestha. Thank you so much for giving me this opportunity, and I'm really excited for this interview.
Okay, thank you. So can you please tell me about yourself?
So sure. I'm Sushma Srinivas. You can call me Sushma. I was born and raised in India, and I did my medical schooling there as well. Once I passed out of medical school, I started pursuing my dream of becoming a psychiatrist. So I initially worked as a research assistant at the National Institute of Mental Health and Neurological Sciences, NIMHANS, in India. And following that, I gave my USMLE steps, and I've even cleared my step 3 as well. I've gained around 1 year of US clinical experience, and I also have 1.5 years of research experience. And right now I'm pursuing a fellowship in psychotherapy to improve my skills of therapy. So and I've also been like actively publishing papers, and I have around 8 submitted papers, published papers, and a few more under submission. So this is all a little bit about my career. On my personal side, I've grown up in a large family of 10 people in India, and I've been like happily married for the past 10 years. And all these people have been my support system during my pursuit of residency. And in my spare time, I love to hike, I love to travel. But the thing that I enjoy doing the most is I love to cook. So every opportunity that I get to, try something new, in my kitchen, I jump on it. And that is what helps me relax and de-stress. So this is all about a little bit about me in a nutshell. Is there anything else you would like to know in particular?
Okay, nice. Great, Dr. Sushma. It was really nice knowing about you. So now moving forward, okay, so can you please tell me why this specialty, why you are choosing psychiatry?
So I think my love for psychiatry started initially in high school when I used to read a lot of fictional novels like Sidney Sheldon, Mary Higgins Clark. That's when I developed an interest. And then when I was in med school, during my psychiatry rotations, I actually got to see a lot of patients, and my interest actually developed there. And at the same time, I had a personal experience where I had a family member going through an addiction, and a psychiatrist really helped save him and my family. That is when I realized the impact of psychiatry, the impact it can do to help people recover, and it can even help families as well. And following that, I also once I moved to the US, again, US clinical experience. But I would say my real interest for psychiatry developed at at NIMHANS, the National Institute of Mental Health that I mentioned. It was a very busy OPD in outpatient in India, and I used to see a lot of schizophrenic patients for my study. And I realized that although they all had the same pathology, no two schizophrenic patients were the same. Everybody had a unique story. Everybody were like so different. And this really increased my passion for psychiatry. And it also at the same time was always very fascinated by the human mind. So I realized that psychiatry was a perfect interface between the human mind and the emotional aspect of human beings. So, and this I realized would give a true meaning to me, helping them feel better, making them get better, would give a true meaning to my life. So ever since then, I've been very passionate about psychiatry, and I've been pursuing it, very dedicatedly, and I cannot see myself in any other field. Thank you.
Okay, so nice to know about that. Okay, so let me take you back while you were working, okay, in your working days. So can you please share with me any conflict that you went through while working in your workplace? Yeah,
Sure.
anything.
One conflicting situation that comes to my mind was, back when I was in India. I was working in a hospital in the internal medicine department as a junior resident. So during one of my night calls, I got a call from the emergency department to go to consult a patient who was delirious, and he was found lying on the street. And this patient was very aggressive, and he was basically like hitting the nurses, and he wasn't responding to any treatment. And I realized his breath was like reeking of alcohol. So the attending physician in the also another junior resident in the emergency department was continuing treatment, and I recommended that it would be better to get a CT in his case to rule out any brain injuries. But when we spoke to the patient's family, we realized that they were extremely poor. They couldn't afford, CT, and they wanted to just get him treatment and take him home as soon as possible. But and the junior resident concurred, and she kept treating him for alcohol, which actually also like made sense. But I wanted to be sure, and I wanted to cover all grounds. So I tried to like convince her, and then we both decided that we will talk to our my attending. And when we explained the whole situation, we left it to his experience and his acumen, and he said that it would be better to get a CT at this point. And when we did a CT, we found that he had a traumatic brain injury, and he was treated accordingly. So in any conflicting situation like this, what I would do is, my ultimate goal is resolution. So I would talk to the other party involved, like try to weigh the pros and cons, and end of the day, whatever decision I take will be in the best interest of the patient.
Okay, that's okay. Nice to know about that. Nice approach. Okay. So now I would like to ask you, so what are the strengths that you have? Can you just briefly just explain about your three most powerful strengths that you have so that you can take you as a resident in our program?
Sure. I have some strengths that have gotten me this far in life. I'm a very adaptable person, very easy to work with, and a very fast learner. So that would make me a very good resident. I'm also a very empathetic person, and I always go out of the way to help people in need. So this will help me build long-term relationships with our patients, with my patients, which is the most important thing in psychiatry. And I also am a very resilient person and a very persistent person. So I remember, like back in the day, as soon as I finished my undergrad, I did not get into medicine in my first attempt. When I didn't pass the MCAT equivalent exam to get me the seat. So I joined dental college, and I did around 3 months, but I kept realizing that I was missing medicine. So I decided to take a chance and believe in myself, and I dropped out of dental college, and I actually worked hard and focused my all my attention on getting the medical seat the next in on my next attempt. And looking back, that was the best decision of my life. So these are some of my strengths that have gotten me this far in life and will help me in residency as well.
Okay, great. Okay, Dr. Sushma, do you have any questions for me today?
Yes, I have a couple of questions. I wanted to know, what are the research opportunities in your program?
Okay, and any other questions?
Do you have any dedicated like research time for residents?
Okay, nice questions. Okay, so okay, this our first session is this, and yeah, I would like to just take the feedback from the Dr. Nadi, and we can move to other session. Thank you, Dr.
Thank
Sushma.
you so much, everyone. Thank you, Dr. Shrestha. Thank you, Dr. Nadir, for this opportunity.
Thank you.
Thank you both. Thank you both. This is excellent mocking interview. So I like the way you present yourself. You have a very nice smile. You answered the question the right way. You gave not lengthy or shorter answers, which is important. You put the key point there. So all in all, you did great. What you want to improve on, I think you may try to give some hints or some dates or some areas in your answers where you want them to go in details to track you into, let's say you did a fellowship or you did present this in this or you publish this and you found it informative and whatever, so that they will ask you, tell me more about this publication, or tell me more about this fellowship, or tell me more about your research project. So you just give them some hints to move around. But in all, I think you answered very good, excellent. The other addition, if you want to, is using your hands. So your camera is on your face, which is great. But the other body language you did not use, you did not convince. So when he asked about the three qualities or in strength, so you can use your hands. So I have done this, and then because you're gonna tell them a story about the first one. So by the end of the story, you want to get them back to the second one. So to keep track, something like that. It's kind of whatever you use your hands for. So, but all in all, I think it did great. Any other feedback from the other fellows? Please jump in or raise your hand. One important thing I think everyone should know, your internet for the technical thing, you'll be ready with your computer, your camera, but make sure your phone also available just in case you want hotspot or you want to use your phone in case sometimes the camera or the computer or the internet might not be the greatest, so you have a backup. So this is in general technical advice.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir. Yeah, now moving towards our next session, Dr. Niki and Dr. Naureen will be conducting next session. Yeah, go ahead, Dr. Niki and Naureen.
Thank you, Dr. Shrestha. And how are you doing today, Dr. Niki?
Hi, Dr. Naureen. I'm doing great. How about you?
I'm fine, and thank you for accepting the invitation. And let's start with the interview. So can you tell me about yourself?
Thank you so much, Dr. Naureen, for giving me this opportunity. So I'm Niki Shrestha. I was born and raised in Kathmandu, Nepal. I was the youngest in my family, and both of my parents are professors. I grew up as an enthusiastic learner, and I was very inclined towards academics. And with my passion for medicine, I joined my medical school and graduated in 2017. After my graduation, I worked as a medical officer in a tertiary center in Nepal for about 2.5 years in the emergency medical floor unit and the ICU department. During that time, I was also involved in various volunteering activities in the remote places of Nepal. This experience helped me mature as a physician and develop my problem-solving and leadership qualities. In 2020, I moved to the US and I've done several clinical rotations, and I worked as a medical assistant in the Department of Corrections and Fairfax County Health Department. I've been involved in several research projects, which has given me a newer perspective towards the evidence-based medicine practiced here in the US. And one of the publications that I have worked as a first author is the correlation between the REM sleep behavior disorder and Parkinson's disorder. All of these experiences has helped me to broaden my medical knowledge and made me familiar with the American healthcare system. And personally, I'm a very social person, and I love to spend my time with my friends and family whenever I have time. I love traveling and swimming. And today I'm very excited to be here because serving a diverse group of patient population aligns with my goals of being an internal medicine resident in your program. Thank you for considering me.
Yeah, you have a very broad experience. So why do you want to continue internal medicine? Why?
So I have decided to pursue my career in internal medicine because of my professional and personal experiences. So professionally, I really enjoyed my third year internal medicine rotation, and my job as a medical officer in Nepal and my clinical rotations here in the US all have been focused in the discipline of internal medicine. I have really enjoyed working and interacting with the adult population, and I love taking care of the elderly people. I have also been highly influenced and inspired by my fellow physicians and my preceptor's diagnostic acumen. I am really fascinated with the diverse range of opportunities we get as an internist. And also, it is very interesting that we get to see a broad range of clinical cases and treat a diverse range of patient population. Personally, I have taken care of various family members with acute and chronic illnesses, and that has made me realize the importance of long-term and continual care. Therefore, I would like to be a physician who can make a positive impact in a patient's life and practice as an internist. Yeah, thank you.
Great. So how do you handle stress? Can you tell me about a little more?
Yeah, sure, Dr. Naureen. So I think that stress is inevitable in especially in our profession, in our medical profession. And during residency, we have to work for long hours and we have a lot of commitments. So we will have stressful moments. But from my past experiences, I have learned some coping mechanisms. For example, when I was doing my internship in the medical school, I found myself in a very stressful situation because it was the first time that I was doing my 24-hour duties, and we were rotating from one specialty to the other, which I found very stressful, and I could not sleep properly. I found myself to be sleep deprived, and at the same time, I had to study for my exams too. So in that situation, my parents noticed that I was really stressed, and my father gave me some tips at that time, and which I have been following for quite some time. So the things that I do is that I make a work schedule in advance for my call schedules, for my work study time, and also my personal time, including exercising and meal preparation time. And that, I think that really helps. The second thing I do is, like, if I find myself in a stressful situation in a hospital setting or in my work, I try to take like 5 minutes break every time I find I can, and I take like a water break or a coffee break, and that I think helps me to rejuvenate and refresh myself. And other than that, whenever I have spare time, I try to do whatever I like personally the things that I love to do, and I hope to do the same things in my residency so that I do not feel very stressed. And if I do feel very stressed, I would reach out for help to the people I can. Yeah.
Great. So going back to the second question, why do you want to join our internal medicine residency program?
Thank you for asking that question, Dr. Naureen. So as I was looking for the programs that I wanted to pursue my residency in, there were a lot of things that really stood out to me about your program. And I think that it would be an honor for me to be a part of such a highly reputed program. The first thing I'm really impressed is that I think I will be getting a very well-rounded and a broad-based training with a strong and a structured academic curriculum and an excellent faculty members. The second thing is that I was really impressed with the research opportunities that you have, and it was really good to know that your residents are participating in national conferences, and I would like to be a part of those kind of conferences and projects. And thirdly, I attended the meet and greet session with the residents, and they were so friendly and supportive that I feel that I will be practicing a residency in a very nurturing environment, and I would love to be a part of those kind of teams because I thrive in a collaborative environment. And lastly, I'd like to mention about the place. So this place, I have been living here for about 2 years. I have my family here, and it would be great for me to pursue my residency here, as I would have a good network of support system. That is why I would love to be a part of your family. Thank you.
Great. So you were mentioning about your work experience back in your home country. Can you elaborate a little about it?
Yeah, sure, Dr. Norin. So I worked in a tertiary setting in Nepal, in a hospital named as Rawan Hospital. I worked as a medical officer for about 2.5 years. I was working mainly in the emergency department, but I was also looking after the medical floor unit and the ICU unit. So in the emergency department, I was in charge of the emergency department during the day, and I was leading a team of nurses, nursing students, and healthcare workers. My responsibility was to take care of the acute cases that used to come in the emergency department, and there used to be about 20 patients per day. And I was also responsible for, besides history examination and ordering the diagnostic test, I was also involved in doing the minor procedures, the minor medical, surgical, or orthopedic procedures. And I was responsible for collaborating with the attending there and managing the patients if they required any admissions or not. And I also took care of the patients who were admitted in the medical floor unit and taking morning rounds and updating their history to the attendings. And for the ICU department, I used to be posted once a week, and my duty was there to work under the supervision of the attending. And I was also involved in several health campaigns and health screening campaigns that the hospital used to organize. And it was a very meaningful experience because at that time, I learned to work under a high stress and practice cost-effective care because it was a resource-limited setting, and I was able to develop my leadership and problem-solving skills. Yeah. Thank you.
So thank you for being here. And do you have any questions for me?
Yes, Dr. Naureen. So I had a couple of questions. So what do you think is the greatest strength of your program?
Okay, great. That's a great question. So it can be answered later. So we can continue with Dr. Nader. Dr. Nader, do you have any feedback regarding this mock interview?
Thank you again. Thank you both. This is also a great one. So I like the way you answered. You are straightforward. The camera, the angle, the light. I think you did great. So all in all, I wish you all the best. You both you did great. So again, I think the only thing you used your hand, but I think the camera was a little bit higher. So I did notice some fingers here and there, but not the whole hand, which is you can fix it later. But I think you also put some details in the answers, which is great. You use the name of the person, the program director here, which is great. So I want from you guys when you have interview, mostly they will tell you who will interview you. So if you can search that person, see what their interest and what publication if they did, what hospital they cover, something like that. So at least if you want to ask some of the questions to them, it will be personalized and it will show that you did your homework searching them. In the interview or during the interview, it's better to use the name of the interviewer when they ask you a question, as Niki mentioned here. So at the end of each answer, or at the beginning, you can mention this is how I did it, Dr. So-and-so, or something. So when you mention the name of the person during your interview answer, I think this will make something more than so so if you have this
Dr. Nadir, you are muted.
sorry. So when you talk to the person with your you put the name down or you tell them their names at the end of your answers or in the beginning, You will remember this person when you're taking note later about the program, and they may remember you better when you mention their name. So when you write like a letter or email thank you note, you will know exactly which one interviewed you and so forth. So it's gonna be helpful to you guys. But in general, I think Niki, you did a great job. Thank you, Naureen, and thank you all.
Thank you so much. Thank you so much, Dr. Nader. Yes.
Khulud, I think you have, go ahead.
Yes, Assalamualaikum.
Thank you.
Are you everybody? Yes, I like the interview for Dr. Niki and for Dr. Sushma. I love it. Both of you did great, and you
Thank
look
you.
very confident. I love the way you are just doing the interview. I have a question for Dr. Sushma, if she's here. Just like I get lost in the conflict.
Yes.
The conflict question, he asked you about the conflict. Did you face in the, maybe you tell a story? Just can you clarify what did you say? Because I get lost between the patient enter the ER, then you like he's alcoholic or has a head trauma, or how did you resolve that conflict?
So how I resolved that conflict was involved my attending, because both of us were right in our own places. So we actually, once I involved the attending, I left it to his decision, because I judged. I mean, I respected his experience and his diagnostic acumen more than me. So then he recommended that we do a CT. And when we did the CT, we actually found the a traumatic brain injury, and then we referred him to the neurology neurosurgery department, and they took care of the patient. So that is how I resolved it.
Okay, that's so good. Thank you so much. Dr. Nader, do you think like when I have a conflict, I have to resolve it myself first, then I will give it to the other upper than me, like attendings or anybody else, or I have to do something first, then I will just transfer it to the other one superior?
So I think the idea of the question is not how you solve the issue. I think what you how you handle a stress situation. So you can do it in a format of a story, as mentioned here, or you can divide it into three parts. The important keyword you want to use, or the important, as Sushma was mentioned at the end, is your focus is the quality of care for the patient. So the patient comes number one. So if they end up knowing that, I think that's number one answer for you, or the component. Then you can be talking about yourself. What's your skills that you use as far as the situation? So you say, I did this, and then I try to reach out for this. So you can reach out for the attending, for your who like senior, or you read about it or whatever. So the details comes in the form of what skills did you use and who you try to reach for guidance if you needed some help. So these are the key points in your answer. If you include this, I think that will be a good answer. If that makes sense for you guys.
Thank you, Dr. Nader. Thank you so much. That's so good. Thank you, Dr. Sushma. Thank you so
I have
much.
one more thing to add, Dr. Ahmed. So in one of my interviews, when I was asked this question, I had told them about, like you said, a story where I had resolved the conflict. So that time they'd come back with the question asking, what if you couldn't resolve it? What would you do then? That's why I decided like to pick this story, because it shows that when I cannot that everything, I mean, I don't know everything. And when I cannot resolve something, what's the steps I would take? So yeah, that was the thing. I don't know if it makes sense. Yeah.
Yes, it does make sense. Thank you so much.
Thank you.
Good luck. Thank you.
We have Dr. Dua.
Yes, I would like to comment on the same topic. So I think the idea here is that they want to test how you resolve conflict. And the idea here is basically, as Dr. Nader mentioned, that the patient comes first, you ensure the patient safety. The other thing is that if you find any way to communicate with the person you're having conflict with and to find resolution before going to the supervisor, this would be better. So you don't come as a patient who causes any issues, and to be familiar with the ladder approach, which you basically talk to your colleague and then you go, if it doesn't resolve, you go from there to your superior and then anyone who's above that.
Excellent. So, and please understand that when you go into residency, at least at my time, when you will become the first year, you will have a supervisor, the second year mostly, or maybe third year resident. So they will be with you. So if the clash is between you and another first year, so you will try to solve it and then involve the superior or the second or third year if you need some help. So this is the, as Rawan mentioned. But you can also, if there is something that you think needs more attention or experience, then you can go up to reach for the attending, for example. And that always comes as your goal is to assure the quality of care for the patient. It's not about you or about the person who did wrong or something like that. Excellent. Thank you so much.
Thank you so much, Dr. Nader.
Good luck, both of you.
Thank you.
All
Thank
of you.
you.
Thank you.
Thank you, Dr. Nader. Thank you, everyone. Thank you, Dr. Niki, Dr. Bijay, Dr. Naureen, and Dr. Sushma for this mock interview. Moving forward, our third presentation today is medical education during COVID-19 lessons. I would like Dr. Rawan to take over and go with the presentation, please.
Yes, hello everyone. Good afternoon, and thank you for the presentations and the mock interviews. They're very helpful. Dr. Mihir, if you'd help me with the slides, please.
Yes, just give me a minute, please.
Okay.
Sorry, I'm having some technical difficulties. Dr. Nadir, do you have the slide, please? I'm just not able to open up in mine.
Just give me a second. I'm trying to access mine, but sometimes my phone doesn't work. Hold on.
Or if Dr. Nadir has a slide.
Okay. Okay. So can you guys see my screen?
Yes.
Okay, great. So today we'll be talking about medical education and how it has changed since COVID hit. So there are a lot of things and a lot of factors that have changed due to the pandemic. So what we're going to discuss, or the main points, are that health profession students are essential, decision-making in the times of crisis, competency-based medical education and the role of telehealth, tele-interviews, and anything that is done over the internet, wellness, equity, diversity, and inclusion, and the student voice. So medical students.
Can you make the
Yeah.
screen bigger? Like, oh, I cannot see it. I'm not sure about the other.
Yeah, so that's the problem. I'm on my phone now, but
Okay.
I'll try. Hold on. Is it still small?
It's good. No, it's good. Good now.
It's good. It's like
I can use share my screen. Let me do that. Is that okay, guys?
Yes, it's good for me. Can everyone see the screen?
Yes.
Okay.
Yes.
So moving on to the next slide. So this is what we're going to discuss, and we moved on to the next slide as well. Okay, so medical students and other health profession students are essential members of the health workforce. So what are the main determinants of professionalism? So the primacy of patient welfare, such as altruism, trust, and patient interest, patient autonomy, and social justice are the main determinants of a physician being professional. And these have been the primary determinants ever since 2002, and it still holds true to this day. So when we think about the priority of learners in the clinical setting, we usually think of it in a pyramid shape. And the most important thing that we used to focus on pre-pandemic was patient care and safety, and student learning comes second, and then public or population safety was not given as much attention before COVID. So when students were learning, or when they were in a clinical setting, they were taught in a way that patient care and safety comes first. So this is the pyramid, which has changed drastically after the pandemic. Next slide. So before we see how that pyramid has changed, let's look at the risks in clinical settings when you're training students. So even before the pandemic, there was some level of risks for med students in the clinical setting, and it depends on the level of the risk, the skill level of the learner, and the responsibility of the team and the patient. So, for example, if you were to do a routine exam, looking at the axis, we have two axes here. The x-axis indicates increasing disease severity risk, and the y-axis is increasing risk of exposure. So if we look at certain procedures, if it's invasive, we have a higher risk of exposure and a higher risk of getting the disease. And if it's a routine exam, the risk decreases. And if we look at it from a disease perspective, if you have a patient with influenza with the appropriate PPE, they'll have a lower risk of disease compared to Ebola. So this is a general consensus of the risks for med students during clinical settings. Next slide. So what was unique about COVID-19, and how did it change clinical practices for med students? So it was a disease that was evolving quickly, very transmissible. It had an asymptomatic contagious phase with a high morbidity and mortality, and it has spread drastically. And all of this happened while we didn't have any available testing, and there wasn't sufficient PPEs. So the pyramid has changed in a way where we now care about public and population safety, and it has the most area, it has the greatest area in the pyramid. And patient care and safety comes second, and student learning, as you can see, the area is smaller because students weren't allowed into the clinical setting because we didn't have enough PPEs and we did not want to expose people to a patient with COVID unless it's very necessary. So this is how the pyramid has changed after COVID. So what do organizations such as medical schools or residency programs do when they're facing a time of uncertainty? So they start with focusing on the mission, the value, and the data available, and then use these to make decisions, while also acknowledging that there are some data gaps, and there are ethical values and conflicts that they have to resolve. And then they have to create rapid cycle core teams that helps make decisions about who rotates, where they rotate, who should be available in the clinical setting. And then it's important to have outsiders or reviewers outside the clinical setting that tell us if the process is working, if what we're doing is correct. So this is how they address a time of uncertainty or COVID. And of course, it's very important to understand the importance of communication. So it's important for the medical schools to communicate directly with the students and tell them that, well, you can't rotate today, or this month we won't be able to rotate because of COVID. There was a high level of satisfaction in residency programs and medical schools that actually communicate better with their students and their residents. So there were some guidelines that were released on the March of 2020 for medical students in locales in which there is a significant active current or anticipated COVID-19 community spread, and or limited availability of PPE, and or limited availability of COVID-19 testing. The AAMC guidance remains that unless there is critical healthcare workforce needed locally, we strongly suggest that medical students not be involved in any direct patient care activities. The primary goals of this guidance are bending the curve for the public health of the community, conserving limited PPE supply to keep healthcare workers and patients safe, and maintaining public and healthcare workers' safety, given limited testing availability. So as we discussed in the pyramid, our main concern was the public health, and we were trying to decrease the amount of students in the clinical setting because we didn't have enough PPEs and we did not want to expose people to COVID patients. And the guidelines that were released were basically telling us that students are not needed at that specific stressful time during COVID in the clinical setting. But then there was another guideline that was released on August 2020, which says in our current healthcare system, medical students are not essential healthcare workers on a day-to-day basis. There is no defined set of responsibilities for which there is a medical student position that must be filled during the clock, 365 days a year. However, medical students are the essential emerging physician workforce. This guidance is based on recognition that to address ongoing national physician workforce needs, the clinical education of our medical students, including their involvement in direct patient contact activities, which may involve patients with and those without known or suspected COVID-19, must continue, with appropriate attention to safety in the context of the constantly evolving conditions that define the COVID-19 pandemic in the United States. So what they're saying is that if we don't continue education for medical students, then we'll delay their graduation, and hence we won't have interns the following year, which will decrease our workforce. And therefore, we have to continue teaching students in clinical settings, especially when the numbers have gone down. Next slide, please. So the critical need to accelerate progress in competency-based medical education. So what happened is Students in their final years were accelerated to graduate, and residents doing ER were shifted into internal medicine. Some people who were working outpatients were shifted into inpatient, and they were working in positions where they were not necessarily comfortable. So there was a disrupted teaching, learning, and training process during the COVID-19. So this has actually highlighted the importance of competency-based training for residents and med students. Okay, next slide. Next slide, please. Yeah, so what is competency? It's an observable ability of a health professional related to a specific activity that integrates knowledge, skills, values, and attitudes. So competency-based education is an outcome-based approach to the design, implementation, assessment, and evaluation of an educational program using an organizing framework of competencies, a mental model or way of thinking about education. No single meaning or model of competency-based medical education, but many characteristics. So competency-based education has been going on for about, I think, a decade, but we haven't really used it as much as we should have. And the difference between the education we used to use and the education we want to be using is we should focus more on the results, and we should focus more on the application-based or experimental results, and the demonstration of experiences and the performance. And it has to be learner-centered and patient-focused, opposed to, can you go back? Yes, as opposed to what we used to use then, which is the what and how of education and the time and the emphasis on knowledge rather than the application. And written tests, we used to think that written tests are the best way to test students, but now we are moving towards using performance as a way to assess students. And back then it was teacher-centered, and now it's learner-centered and patient-focused. So now we're going to talk about virtual learning and virtual interviews and telemedicine. So virtual learning and virtual interviews and telemedicine has helped us a lot during our COVID pandemic, but the AMC still thinks we need to do some research, because yes, it has saved us money and it has saved us time, and people were more flexible. But for example, during a residency interview, some people say that it would be better if we are in the program so that we can get to know the program, and the director could actually see you and get to know you personally. So as much as it has been a help, but people still sometimes think that it's better if we have an in-person contact during education or interviews. So research still needs to be implemented to see which one's better. So what we've learned mainly from COVID-19 concerning medical education is the importance of healthcare workers' wellness, equity, diversity, and inclusion, and the student's voice. And that concludes my presentation. Thank you.
Thank you, Dr. Rawan. Thank you, Dr. Nadir. Dr. Nadir, do you have anything to say on this?
Thank you. Thank you so much, Dr. Rawan, for this excellent presentation as well. So yeah, as far as our experience here at MSU, so we have COVID affected some of the students of the education. So we changed from in-person to mostly tele, and then we have to create some courses or classes that can offer some of the knowledge, the skills remotely. Like the interview skill instead of one-on-one person, like patient in a room, we can create patient encounter remotely. And here we use also simulated patients. So instead of in the room, the student will examine and ask the patient, they will try to do it remotely. So we have SP remotely. But mostly we ask the students to come to the hospital later after we have better control of the disease and we know we have enough PPE and vaccination and so forth. So I think the first year was tough, but later on people were open to accept the students in clinical settings. But it was a different experience for the students, but it was a challenge that made it good opportunity for step up and come up with some new approaches as far as remote education, telemedicine, telehealth. Anyone with any experience in this area or you know, medical school or taking care of patients remotely or education remotely? Want to input from anyone?
Dr. Nadir?
Yeah.
I think I can give some reflections onto that.
Sure.
So during COVID, of course, everyone had some limitations, and I had a chance to do some like more like a online remote work. So like a tele rehab, and when we were all limited with our going to the different units, especially with the COVID, with the first wave, with having a very limited PPE and limited resources, not everyone were allowed to go into the COVID unit. Of course, the therapy at that time was not a primary, because of the medical necessity of the COVID patients, because of their severity. So of course, we were not in front line at some point. We were at somehow also, but especially in acute care also, like most of the rehab staff was actually used as a assisting medical professionals, mostly like proning patients, and that was very important in acute care. But in subacute, I was doing a more assessment remotely, where nursing staff was actually taking their devices to the patient's room, and we would actually see those patients remotely. So more like assessing. There was a different challenge, because as a therapist, we are 100% of the time with patients, assisting or assessing physically, assessing their strength or their balance in standing there. So everything we used to do, then now we had to think differently, and now you have to approach differently. So in that case, I was actually assessing, I was assisting or providing command to nursing staff what to perform, what to do, how patient would react, and how would they perform. And then based upon that assessment, we have to actually create that intervention, set up some protocols, and go from there. That was a different experience than what we used to do. So yes, it's a unique learning experience also. And we along with that, we have to make sure that we follow all the policies and procedure, including HIPAA. So yep, that I think is good. Thank you.
Excellent. Yeah, thank you so much, Mihir, for sharing. This is excellent. Yeah, and one of the things I think you may think about, maybe an idea, is we can write this experience as an abstract to somebody to ANDA, because Mihir works in a long-term subacute rehab setting, and this patient, we can write some case report, or in this case, maybe tele-rehabilitation experience during COVID, and we can use it as a poster and submit it to, and if you're interested, or if you have something to help you, that might be a good idea, just to share the experience with others. Thank you.
Thank you, Dr. Nadir. So let's move forward a little bit on our next presentation. It's on perception of medical students versus dental students in a medical college in India. So I would like Dr. Tahani and Dr. Amel Saad to present this. Thank you.
Hello, everyone. Do you see my screen?
Yes, we can see that. Thank you.
Hello, everyone. Thank you, Mihir. Thank you all who presented today. So, yes. So we'll present today the perception of medical student versus dental student in medical school in India. So it will be presented by me and Dr. Amel. So we know that lecture have been the most common form of teaching and learning since ancient times. During a lecture, both visual and auditory senses are used to absorb information. A chalkboard is uniquely effective as a medium of classroom instruction and has been used commonly in lectures, while the use of transparencies with overhead projector is also popular. Recently, the use of electronic presentation has become common. And Microsoft PowerPoint is now the most popular package used out of electronic presentations. PowerPoint-based lectures are increasingly being delivered in medical college, as in other colleges and universities. However, educationalists are divided on the superiority of PowerPoint presentation with respect to the traditional Jack and Talk method. Various studies have been conducted to assess the effectiveness of lecture using PowerPoint or other such media in comparison to lecture using chalkboards or the use of the projector. The present study was planned in a medical college in India to assess students' perception of the impact of PowerPoint presentation in lectures compared with traditional Jack and Talk method and lecture using transparency overhead projector. The study analyzed the preferences of teaching aids of medical student versus dental student. So today we're going to discuss this study. The study was done by the following authors, just to give them their credits, and they are in the Department of Pharmacology, Mahatma Gandhi Medical College in India. So the purpose of this study is to assess the student perception of the impact of PowerPoint presentations in lecture in comparison to the traditional Jack and Talk method and lecture using transparencies and overhead projectors. The study analyzes the preference of teaching aid of medical students versus dental students. So they use second-year medical and dental undergraduates were asked to fill a 9-item questionnaire about their perception of 3 lecture delivery method. So following analysis of the questionnaire, the students were interviewed further. The results were analyzed separately for medical students to see if there was any difference in their perceptions. I think Dr. Amel will continue the presentation of this topic. Are you ready, Amel?
Yes, Tahani. Thank you, Tahani. Hello, everyone. Yeah, we'll continue in the same page with Dr. Tahani. The result of the study shows that the majority of the medical students, about 65%, prefer PowerPoint presentation, while 15% of students prefer a lecture using chalkboard. 19% prefer overhead projector for teaching of a significant p-value 0.001. For dental students, 41% prefer chalkboard, and 31% overhead projector, and 25% of students prefer a PowerPoint presentation in the lectures of v-value 0.05. Some important comment of the student were also recorded in the interview, which could be valuable for medical teacher. Here, the diagram show for the medical student. Shows that medical student opinion of the lecture using a different teaching aids, which shows that the blue color for PowerPoint presentation, which has a high percent, and the green one for overhead projector, and the last one for chalkboard percent, which was lowest one. The second diagram show dental student opinion of the lecture using a different teaching aid. Same color, which is the top one for the red one for chalkboard, then followed by the green one overhead projector, and the last one for PowerPoint presentation. From this study clearly highlight the point that of the preference for method of the lecture delivery for of a student in a different faculties can be vary so much in the same institution. Regarding the preference of a medical student, the order of the priority of a priority for teaching it was first PowerPoint, overhead projector, and chalkboard. In the case of the dental student, the order of these preference was top is a chalkboard, then overhead projector, and lastly for PowerPoint presentation. Medical students significantly prefer the PowerPoint presentation, while dental students do not. This is another diagram which make a comparison of preference of teaching aids. Medical student versus dental student. The pink color for medical student preference, and the purple for dental student preference. For medical student, show high percent, more than 60% for PowerPoint presentation, followed by overhead projector, and the last three for chalkboard. And the opposite for the dental student, the top for chalkboard, and lastly for PowerPoint presentation. Regarding regardless of a teaching aid, use of impact of the lecture depend on the teacher. Mean that if there is more example, more diagrams and follow charts, make the lecture more easy and understandable. So we come to the conclusion of the study, which show that medical students clearly prefer the use of PowerPoint presentation, while the dental students do not. The study do not bring out evidence-based superiority of any lecture delivery method. It appears that in the hand of the trained teacher, any teaching aid will be appropriate and effective. This highlights the need for formal training in teaching technologies to develop good presentation skill and thus motivate the student. That is all about this presentation. And thank you. Anyone have a question? Dr. Nadila will have bulk information about this topic. Will help us a lot. Thank you, Dr. Nadir.
Thank you so much, both of you. Great presentation. And I picked this article of this topic because we have dental and medical in the group, but at the same time to show you we don't have to focus on clinical aspects as we are doing our research in this fellowship. So we can look at educational part and we can do some studies similar to this one, comparing with instance of this example, the medical student aspect versus dental student. But there are a lot of educational areas where we can do some study or review things or come up with new ideas or look at perspective of different learners. So all these are available for us to do some research work and present it. There are some conferences or some journals that accept similar work. So we can approach these topics differently. We don't have to focus only on the clinical research part. It's just an optional thing that we can think about. But thank you so much for great presentation. Excellent, excellent work. Thank you.
Thank you, Dr. Nader.
Dr. Nader, I have something to share.
Yes.
Yes. First of all, thank you, Dr. Tahani and Dr. Amel, for this lovely presentation. So I want to say, I just wanted to share some experience, even though I didn't attend any of like medical or dental, but in India. So mostly for my experiences, it depends largely upon your audience, what you're, what you are working on and what kind of situation you're in. When I was in PT school in India, and we had a medical dental both in our same institute. So we often would go for lectures, we had a pharmacology subject, we had other medical subject as well, like ortho, gynec. So we would go often, we would share some of the lectures. So we would go with the medical students as well and dental students. So if you have a small group, like let's say 30 or 40 or 50 students, then there is often chalk and talk discussion. If you're in the large group, obviously more like a PowerPoint presentation. For example, if you're in association, there is a seminar or there is a presentation you do on public places, it's more like a PowerPoint. But chalk and talk, mostly I would say that it's more person to person, it's more face to face, and that actually interacts you more. I remember that when in the first year, when we had an anatomy class, anatomy class, when we were learning about the bones, our lectures were from the medical side, the doctors. And I remember one of the best doctor I may have ever met. He was an ENT specialist, but he was more into anatomy. So we would learn. We would learn in a 15 or 20 persons in a batch, and we would all gather around his desk, and he would show with the bones in his hand all the origin, insertion of the muscles, whatever the structures or the area of the bones we need to learn, we would go. So it was more hands-on. It was more, truly learning directly from the bone itself, what kind of bone it is, either it is a cartilaginous bone or compact bone or the joints and everything in detail. So I think the benefit of that chalk and talk or person or face to face is more hands-on than just going through the PowerPoint slides and learning about it. So and hands-on is much more longer lasting memory. You carry that with you, and whenever you in your clinical practice, whenever you imply something to that, whenever some kind of condition you deal with, any sort of expert you see, you relate that memory with your knowledge, with your expertise, and you imply that in your clinical practice. So.
Excellent. Thank you so much, Mihir. Yeah, this is an excellent point. So in teaching in general, when you talk, it doesn't last enough compared to when you draw. So drawing a picture, for example, means a lot of or carry a lot of information and may last longer. And if you apply the same concept, like 2-dimension, 3-dimension is better. The image, if it's still image versus a video, might be a better video compared to just showing and drawing of a picture. And the better one, as Mihir mentioned, is the 3-dimension or the actual in a real life for the learner. So if you apply that to the learner on their body or on something that they can feel and sense, and then the learner will get the idea better and it will last better or longer. So there are ways of how you deliver the message. There is a simple way, there is a complex way, there is a more complex way, but it depends, as Mihir mentioned, how you can deliver that message and who is the learner. If it's 1-to-1, it's different than 1-to-10, it's different than 1-to-100, for example. If you look at TED Talks, we talked about the videos. We can see some of the videos are made with the background as video as a PowerPoint presentation. So the presenter will use a clicker when the slides go back, similar to what we were doing just in the last session, for example, topic about education. So the presenter will talk and then the slides will change from one to another. If you look at another presentation, yesterday I was watching one of the videos for Dr. Sachs, he's a neurologist. He was giving a few minutes talk about his experience with patients and so forth. He was having a paper and then he reads from his papers. So there's no background to look at. But from the stories he mentioned, from what he was telling the audience, I think it grasped the idea of what he was trying to say because he mentioned it in a story format. And most of us, when we look at things, if you put it in a context like a story, it makes a lot of sense compared to giving you facts for the learner, for example. So it's different. Use it as a tool for points versus talk for other ways. But the best way is the 3-dimension if it's 1-to-1 person, as Mihir mentioned. Excellent. Thank you so much. Any other input or reflection, or what do you think, guys? The way you were educated or the way you're gonna teach? Because some of the interviews might include this. In the past, at least one of the candidates, one of the fellows here, was asked, you like teaching from what we look at your resume. Tell us of what method you use or something like that. What seems to work for you. So any one of you has any input or reflection?
Yes, Dr. Nader.
Yeah,
as I said, yes, regardless of the method of like teaching, it depends mostly on the teacher and how he can just deliver the information, how he can get people excited to get the information from him. And this is the way like we are remembering teacher and not like forgetting them from this long time ago, because they have special methods to get teaching their subjects. And that's why I think not everybody can be a teacher.
Sure, yeah, definitely.
Yes.
Thank you for sharing, Dr. Kolot. Yeah, and one of the things that's recently on the teaching arena, they were talking about the involvement or the engagement of the learner. So there are different ways to get the learner engaged. So there are different methods. So go ahead, Mihir.
Yes, thank you, Dr. Nadir. Yeah, I can talk all day about teaching, even though I'm not in academics or, I don't have direct experience. But so when I did my doctor of physical therapy here in US, my thesis was on distant learning, distant teaching, online teaching, online teaching the students. So in physical therapy. So the method we were using was we had like most of the learning in US, as you know, they have some sort of platform they use, whether it is Blackboard or whatever they use, software, different software. But depending upon their syllabus, depending upon their task, every like they have what we had, what we called a discussion group. We had a separate discussion group. We had a different assignment groups also. So in discussion group, there would be a topic related to from the syllabus, related to the classes and lectures we had. For example, we had for the radiology and pharmacology also. In pharmacology, I would say there is they would talk about particular uh, um classification, drug classification, and then according to the disease. So there is a question they put into the discussion board, and everybody has to answer in a systematic way that they have to. It's not just a yes or no answer. It's a more in detail, more descriptive. At the same time, you have to back up your opinion with your with the evidence-based information. So you have to cite it correctly, whether it depends upon the institution, whether they are asking in the APA format or AMA format. You have to cite it in a certain way, so you don't they based upon the discussion, and you count grades, you get the grades from that. And once somebody posts that, other like classmate has to respond to that. And again, it's not just saying that, oh, I agree with your information, but it's more professional way and more scientific manner. You have to either if you're opposing to that idea or if you're backing up, you have to provide again the evidence based. So you have to provide the answer on that, so that discussion keep you engaged. You learn from something. So, and then you have a chance to do your assignments, whether you're doing as a PowerPoint presentation or different, like you're writing just in Word documents, or uh, providing data using Excel or whatever. But mainly like again, as we are talking about the different way of delivering the methods, teaching methods. So yes, thank you.
Thank you so much for being here.
You're welcome.
Yeah, we can talk a lot about the education. But one story I want to share with you also is like the medical education in Sudan. At least when we were there, it used to be like you go for the basic science and then you go to the clinical in the fourth year or fifth year. When we went to my school, they switched that into an organ-based or system-based approach, where they collect all the heart problems, cardiovascular. So you're gonna read about the anatomy, physiology, everything, pathology, medication about the system, and then you go to the nervous system. So that's the approach at the time. And as we graduate, the approach, the newer approach was problem-based learning. So you put a case, and then during the case discussion, brainstorming, and the students will get involved, as Mihir mentioned. Everyone will contribute, and then you go, you read, and then you contribute again. So that's the approach that was used here in the US and other places, Canada, and at least when we were medical students. At that time was a newer thing. And in the past few years here at MSU, they come up with a newer approach. So the one we are using now, it's from day one exposure for the medical students to the clinical aspect. So they don't even wait for the student to get into the third year or fourth year to do the history taking or examination. From day one, they teach them how to build a report, how to ask a question about what brought you here, how to read the patient, and then they will go over the exam, and then the history details while they are getting the basics of the medical education, like anatomy and physiology. So when they reach mid, like they call it early, mid, and then advanced learning experience, they have at least the basics of patient encounter. When they are advanced, then they will be basically physician ready to jump on the career or residency and so forth. So the approach of teaching is moving faster and faster and changing. So it depends on how you like it or how you communicate with your students to get them engaged. Thank you. Thank you so much.
Dr. Nadir, one more thing, sorry.
Yes.
Just wanted to add a little bit more. Sorry, I'm talking too much today, but so when we were talking about teaching methods, and specifically, as you said recently, how MSU did a more clinical. So wanted to say something about clinicals. So I just want to give a little difference in rural, like back in India. So as you said, same thing that for us also, like we had like 3 or 4 and 5 years of education, and after that you have what we called as an internship we used to go for, which is more like a clinical rotations here, but it is at the end of your program. It's not along with your program. Here the difference is as you start studying here, like first year you start the clinical rotations from the first year. So over there, the difference was after you learned everything, after your 4 years or 5 years of education, you imply those theoretical, your knowledge into your clinical practice. Here, as different is whatever you learn in your classroom, you start implying that on first year. So, and I have been also worked as a clinical instructor. So in the setting. So they have different levels. So the student has different levels you have to comply with. So you have a formal grading system and all that. And see, here I feel that it's not just the treating patients, it's all about how do you approach the patient, how good the listener you are when you're talking to patients, how do you evaluate the patient, what are your ability how professional you are, what are the attributes you put in your clinical practice to improve that quality of care, what are the guidelines you're following, what are the standardized protocols you have, how good you are not just with the history taking or treatment, but more with the documentation. How do you, because collecting the data and putting the documentation in the documentation is very important for us, because it's all insurance based here. So you have to provide not just a quality of care, but also you have to demonstrate your quality into your documentation. You have to reflect that in order to maximize the benefits for the patient. It's all about patient. It's a patient centric. So you have to weigh, and you have to also be more because of your liability as a medical professional. You have to show that through your what the term they use mostly here is a skilled services you have to justify. So yeah, I mean, as I said, I can talk on this all day.
Thank you. Thank you so much, Mihir. Anyone else wants to reflect or share or have any questions about what we discussed during the day this morning in the meeting? I think the presenters were excellent. So thank you all. Maybe we can switch to the last part of the meeting.
Yes, Dr. Nadir. So our last thing is update on the projects. If anyone has any updates.
So I know Sudhafa and Avinash and their team are working on one poster. We're going to present in about 2 weeks, 3 weeks. and ask about the primary physicians in Houston, I think. All right. Anyone else working on their project that they want to update? I know Mikdad and his group also submitted a manuscript to Curious, but got rejected. So I think we can work on that to improve and maybe submit it to some other journal. Anyone else want to share about your projects, ideas, questions, and updates? The next, I think, in 10 days or so, the deadline for AMDA. If you have an abstract that can be ready and we can submit, that might be a good option.
Yes, so Dr. Nadir, for our group, I mean, we started working on long COVID, and for some reason, with everybody was busy with their applications for residency and all that, we couldn't do a whole lot. We're still trying to go work more onto that, and initially the topic was the effect of long COVID on musculoskeletal systems in older population, what we were working on, and we have like gathered some data, and we still in that primary phase of going through that and verifying our data and putting into the paper, and keeping as you said, the PLTC 23 they have from AMDA. If we want to submit the abstract, and I understand the deadline is on 21st of November. So we want to definitely submit. And along with the topic we were working on, I have a couple of other the topic in my mind, and I know most of our group is here today, so I think that's a good chance to just tell them as well. I was thinking a couple of one topic can be on fall risk and fall prevention strategies for older adults with long COVID. In that, we can discuss about the long COVID effect, fall risk factors, fall prevention strategies, and multidisciplinary or interdisciplinary approach. That can be the one topic, and the second can be the post-pandemic stress disorder. After this pandemic, I mean, everybody felt that stress, affected with that. Even as a healthcare professionals, we had that, it affected us also. So I'm planning to go through that, and we'll talk about we'll talk with the group, and we'll decide one, and I will update you. Thank you.
Sounds good. Excellent. Great. Thank you so much, Mihir.
Thank you, Doctor.
Anyone else wants to share? Please jump or raise your hand. In the meantime, I know some of you might have some interviews scheduled in the coming days, weeks. So congratulations, and wish you all the best. I just want to share with you, for all who are preparing for the interview, I collected some of the videos online. So if you go to the app, there is some videos that you may want to look at. This one might be a good one, and so there are a couple of them that we want to review. They may give you some tips, and in the past we shared some of these ones, like interviews by other students or graduates from other programs. So there are other ways to look at what people are preparing, how they are doing, and you can get more tips and increase your chance. And some of the information might be from program directors. So maybe you look at what they say. That might help you. But I wish you all the best, friends.
Thank you so much, Dr. Nader.
Thank you, Dr. Nader.
So for the next meeting, if there is no more questions, can we, I think the next meeting will be yeah, okay. Yeah, so this is just a suggestion for next meeting. The names put in place, you can change. I know some of you might be traveling or preparing for step 3 or other conflicts. So if you are not available, please try to reach to the team leader or organize it by yourself so that we will be ready. If most of the people in this team are not available, maybe you can ask other teams to jump in, team members. So it's just, you can look at the app and you can look in advance. So let's say not next week, the week after, if your team is going to be assigned, if you know you are not available, maybe you can contribute either earlier, maybe next week or maybe later. So maybe you can reach out to the team leader for that day and say, hey, I'm available, I want to contribute with this or that. So thank you so much, all the presenters for today. Thank you, Mihir, for leading the team and the Zoom meeting. Thank you all who are present and those who will come later to watch the video. So I wish
Thank
you
you,
all the
Nader.
best.
Thank you, Dr. Nader.
Thank you,
Thank you
Dr.
so much.
Nader.
Bye-bye.
Thank you so much, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader. Thank you, everyone. Assalamu alaikum.
Thank you, Dr. Nader. Assalamu alaikum.
Thank you, Mihir. Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you. Thank you.
Thank you, Dr. Nader.
Thank you. Assalamu alaikum. Here, if you have a minute, if you are not busy.
Yes, sir. I'm here.
So I looked at some of the, I can share this one, some of the things.
Yes.
So there are some articles there about telerehab during COVID.
Yes.
So if we can look at some of them, maybe you
Sure.
can incorporate your experience or your
Sure.
reflection and see if we can create a small short abstract for, and I think might be a good option. We can just see if
you
want to share.
Do you think okay, I can do that. Do you want me to write something little bit or to present here, or what will be the platform?
If you want to create a document and then you can share the document and see if anyone of the fellows might be interested in groups of 3, 4, whatever, and then you can create it in a sense that you can present it for the abstract, something for.
Oh yeah. Oh yeah. Okay,
and
we
then,
can do that. Sure.
Sounds good.
I mean, yeah, I can actually put into the group if anyone interested. I mean, you can like share some personal experiences as well with telerehab.
Yeah,
absolutely.
Sure.
Yes, I can do that.
Thank you so much.
Thank you so much.
Thank you so much. Yeah.
Have a good night.
Have a good night. Bye. Dr. Talal. If you are there, please go ahead. Dr. Talal.
Yes, Dr. Nader, كيف الحال?
Go ahead.
How are you?
Very good.
We started, to collect the data for our project, okay? But the problem is, actually, I didn't find a lot of data about this subject. And I tried the other database, but unfortunately, all of them, you have to pay and you have to register. actually, I mean, now we have a problem to collect the data itself because, you know, there is no a lot of data. I think in PubMed, only one research about this subject. Okay. The second thing, in the draft, you give us the link, and in that draft, you said 2018. That means we have to search only from 2022 until 2018, because, you know, I have a suggestion for my group. Anyone, we are 11, and anyone, he can take 1 year. For example, from 2022 until 2009. Or only for 2018. This is the, I think I want this to be clarified also.
So it depends on how you look at it. If you want to compare it between during COVID and before COVID, I think it's okay. If you want to do it just in general, you can go back as far as you want, 2009, 2010. So there is no, it depends on how you and the team want to look at how you want to present it. So.
Okay, this is okay, no problem. How we can resolve the problem of data?
So the data, send me which database you want to look at. And because with university, I think I can have access to some of these databases. So send me the
because, you know,
database
you already mentioned many database in the draft, like for example, a British nurse society or something. I found it's closed. Also force knowledge, or this is I have here the paper. You know, many database you mentioned by yourself in the draft. All of it is need to be accessed.
What I did in the draft, I just copied the previous paper and I added so that we can modify it. We don't have to do it the same way, because the database might be applied only in the hospital setting, inpatient setting, and we are talking about outpatient, long-term, and subacute rehab kind of setting. So we can find that in PubMed, or we can find that
Google
on Cochrane or Google Scholar. So we have three. So look at PubMed, look at Google Scholars, and look at Cochrane database. If we can find anything in these three, I think that would be enough. If we have limited data, that also might be a good start. We can write it and then say, this is not studied well in this setting, so we need to maybe find some funding to do some studies.
Okay, that's okay. Thank you, Dr. Nadir. Goodbye. Okay.
Have a good day.
Bye.
Any other questions from the rest? Thank you again, Naureen and Niki, for the presentation, the mock interview.